So we are totally on time. Hello, everybody. Welcome back to the second part of our meeting. Thank you all before for the fascinating talks we already heard in the first part. My name is Heide Sigelko. I'm an adult endocrinologist from the University in Göttingen, Germany. And just to tell you, we already have piloparathyroid in Germany since January, and we took part at the compassionate use program also before. That means that you have earlier access to the medication or to the treatment before. So I'm happy to pass over to Helen Hopkins. She's a co-CEO from Parathyroid UK with Liz Glenister, and she will be here, and I'm really happy to pass over to her. So please, Helen, go ahead.
Thank you. Good morning, everyone. I'm very pleased to welcome our next speaker, who is Tanya Galmetti. Tanya is a registered nutritionist in the UK and has an extensive background in nursing, sports science, and nutrition, having spent the past 30 plus years working to help people improve their health and fitness. Tanya also happens to be a hypoparathyroid patient herself, following a total thyroidectomy early in 2021, which gives her a really unique insight into the condition. We will be structuring this session slightly differently in that we will be doing questions and answers immediately after Tanya's talk, and then we'll follow on with the next one. Thank you.
Good morning, my name's Tanya Galmetti, and the topic I'd like to share with you today is hypoparathyroidism, calcium in nutrition. So quite recently, in 2022, there was a small but significant change to the guidelines for the treatment of hypopara. The European Society of Endocrinology now recommends the use of dietary calcium in the treatment of hypopara, and with supplements being reserved for times when dietary calcium is insufficient. So this is a great change, and it does reflect some of those complications that can occur with the long-term use of calcium supplements. So today I thought it would be helpful to look at some of the issues or the questions that you may have around the topic of dietary calcium, particularly if you've been taking supplements and are looking at making a shift to treating your condition with predominantly dietary sources. Last year, I also completed a research project on hypopara. This was part of a university course I was doing. My study was to compare the symptom experience of persons taking supplements to those using dietary calcium. And I'd also like to share some of those findings with you today, particularly with regards to how much dietary calcium is needed in hypoparathyroidism, and also what is symptom management like with just dietary calcium. So looking at some sources of dietary calcium, our body, of course, doesn't make any calcium, and we need to obtain all of it from the foods that we eat and drink. Fortunately, it's a widely available mineral, and it's found in both animal and plant foods. So here you can see, of course, we've got some dairy foods, we have some soy products, we have plenty of leafy greens, we have nuts and seeds and legumes. We have some canned varieties of sardines and salmon. Canned varieties are the ones that contain the calcium because they also have the bones. In terms of fruit, not many fruits do contain a lot of calcium, but some notable ones are oranges, figs, and apricots. Now, the big difference between all these foods, of course, is how much calcium each of them has, but also with that calcium, how much of it can we actually utilize? How much can we absorb? So the amount of calcium that can be absorbed and used by the body is known as bioavailability. And different foods have very different amounts of bioavailability. The amount of calcium that can be absorbed from a food ranges from approximately 5%, which is of course very low, up to about 68%. There are no calcium foods that we can absorb 100% from. The amount that can be absorbed does depend on several factors, and these include what the calcium in that food is bound to, so what other compounds are within the food, how much calcium the food actually contains, how soluble it is, and if there are any other dietary factors that are present which promote or inhibit absorption. So one of the biggest factors that inhibits absorption in plant foods is the presence of phytates and oxalates. These are compounds that occur naturally in plant foods, and their role within the plant is actually to protect the plant from attack by sort of diseases or insects. For us, it means it decreases the amount of calcium that we can absorb because the phytates and the oxalates bind with calcium, and we don't have the enzyme in our body to break down that bond, if you like. So this can limit the amount of calcium that can be absorbed. Now, oxalates are the strongest inhibitors of calcium absorption. They're not found in that many foods, but they are found in large amounts in spinach, rhubarb, walnuts, and legumes. Phytates are less potent absorption blockers, but they will still limit your calcium absorption. Phytates are found more in whole grains. They're also in some nuts like Brazil nuts, almonds, hazelnuts, and walnuts. They're also in seeds and in legumes again. Now, the difference with phytic acid over oxalic acid is that it can be partially destroyed by digestion. So the acid in our stomach does partially break down the phytate, and cooking processes can also affect it. So things like boiling and soaking. Now, with oxalates and phytates, not only do they inhibit the absorption of calcium from the food that they're in, but they can also affect absorption from foods that you're eating at the same time. So a really good example of this would be eating spinach at the same time as cheese. The oxalate in the spinach will limit how much calcium you can get from the spinach, but it will also the amount that you're going to get from the cheese at the same time. So how much of an effect phytates and oxalates have in terms of overall calcium absorption is somewhat debatable. It's generally believed that in persons who are eating a mixed diet, so the diet has dairy sources of calcium as well as plant sources of calcium, and if they have no absorption issues, then it isn't a problem. But in persons perhaps that aren't having very many dairy foods, which could include people with hypoparathyroidism, since high amounts of dairy aren't actually recommended for us because of the presence of all the phosphates. If your calcium sources are predominantly coming from plant foods, then certainly I think you need to be aware of the effect of phytates and oxalates and compensate for the reduced amount of absorption that may be occurring by just adding some more serves throughout the day of different types of calcium. Certainly wouldn't recommend that you don't have foods with phytates or oxalates in them. Phytates in particular do have other health benefits. They're known for lowering cholesterol, they can slow digestion, and they can prevent sharp blood sugar rises. So they're definitely great compounds in other ways. There are some other dietary factors that also affect absorption. So the presence of protein, we know, can increase calcium absorption by improving solubility. We also know that sugar can have an impact on absorption. So lactose, which is milk sugar, helps increase absorption. It's thought that excessive amounts of fructose, which is fruit sugar, and sucrose, which is table sugar, may be associated with a decrease in absorption. Fermented dairy foods are another interesting one. So things like yogurts and kefir and even smelly cheeses, blue cheese. These contain pre and probiotics, and this can aid in calcium absorption from the large intestine. So this is achieved by altering our microbiome, and this can help increase absorption that happens in the colon rather than the small intestine. The presence of caffeine and tea in our diet may also have a bit of an effect. This is because, of course, caffeine and tea also contain phytates and tannins. However, the effect is probably negligible unless you're having really large amounts. So just to put that all together and to show you kind of how it works, here is a small table on the bioavailability of some calcium foods. So we can see up the top we have cow's milk, and a cup of cow's milk contains roughly 300 micrograms of calcium, and it has a bioavailability of 32%. So from your serving of cow's milk, you're going to absorb around 96 grams of micrograms of calcium. If you look down there at spinach, you can see that a cup of cooked spinach contains a really large amount of calcium. It's got 243 micrograms in it, but the bioavailability is only 5%, and that's due to the oxalates. This means that from your serving of spinach, you're only going to absorb around 12 micrograms. If you look at the other green veggies there, like broccoli and kale, particularly kale, which is quite a decent source of calcium, they have a much higher bioavailability, and that's because they actually don't contain very many phytates or oxalates. And then looking at chickpeas and almonds, you can see that they don't contain a great deal of calcium, but they do have a high amount of phytate, so that limits their bioavailability to around that 21%. So this is just showing you the differences between some of the foods. So in addition to dietary factors that can affect absorption, there are also some physiological factors. So these are things that we actually can't control. The biggest one is that absorption is just physiologically limited. Calcium is a really large mineral, and we're actually only able to absorb roughly 25 to 35% of what we consume each day. And in some people, this number is actually lower. The relationship between calcium intake and absorption is also an inverse one. What this means is the more you have, the less you actually absorb. So for example, if you were just to have an intake of 200 micrograms a day, which I wouldn't recommend, that's a very small amount, you would absorb about 45% of that 200 micrograms. But if your intake goes higher, so you're looking at intakes of above 2,000 micrograms a day, then your ability to absorb drops right down to around 15%. So basically, the take-home message with calcium is more isn't necessarily better. Our body has a limit. Now, that limit applies to how much we can absorb each day, but it also applies to how much we can absorb in a serve. And the amount we can absorb per serve is believed to be around the 500 microgram mark. This doesn't mean, of course, that if you were to have 500 micrograms of calcium that you will absorb all of that, but that is the capped amount. Going above servings larger than that serves no purpose because you won't absorb it. Some other things that do affect absorption are, of course, age and gender. Calcium absorption naturally decreases as we age, and also with menopause, with the reduction of estrogen comes a reduction in the amount of calcium we can absorb. So moving on to how much dietary calcium do we actually need? Recommendations for calcium vary by country. You can see here just on the table that I've given the UK, the USA, the World Health Organization, and the European recommendations. And they vary between 700 micrograms a day and 1,300 micrograms a day. Now, with hypoparathyroidism, there is no data on the calcium requirements that we need. Okay, that data doesn't exist. There is some recommendations for persons with other diseases, in particular celiac and inflammatory bowel disease. And you can see that their requirements have increased a little. So it is possible that the requirements in our condition could also be slightly larger than the recommended intakes, but currently this is unknown. So as I mentioned last year, I did a study, and one of the things I looked at was dietary intake in the persons participating, and I compared their dietary intake to their symptoms. So this graph shows you the symptom frequency, the symptom severity, and the quality of life ratings experienced by people participating. And this graph has the various calcium intakes that they were taking along the bottom. Now, if you look to the 1,000, 1,300 mark, you can see that the lines all take a dip at the very same amount. So what this is essentially telling us in that persons who weren't having any supplements, these were people that were just getting their calcium from their diet, their symptoms were improved at the 1,000 to 1,300 mark. This data, of course, is by no means conclusive. The research isn't published yet, and further research definitely needs to be done. But what it is showing that there is potentially an optimal intake that may exist in our condition that helps improve symptoms. And lastly, looking at symptom management. Again, the study was looking at the persons who take supplements and people who were just managing the condition with dietary intake. And so what I asked them was a whole bunch of questions on their symptom severity and their symptom frequency and their quality of life. And then I compared the two groups. So 57% of persons doing the study were taking supplements and 43% weren't taking any supplements. And so we see here, this is the results for the quality of life. So this is the perceived effect of hypoparathyroidism on quality of life and the various variables you can see. And this is the percentage of people who reported a frequent or always impact on quality of life. The calcium supplement takers are the blue lines and the non-calcium supplement takers are the green lines. And what you can see here is for these variables, there's very little difference between them. So the impact on quality of life was pretty much the same whether you took supplements or didn't. Likewise, for symptom frequency, this is the percentage of persons who reported experiencing symptoms frequently or all the time. And once again, you can see that between the calcium supplement takers and the non-calcium supplement takers, the percentages are exceptionally similar. So their experience of symptom frequency for bone pain, anxiety, tingling and numbness, brain fog, body temperature changes and tiredness was exceptionally similar. And lastly, symptom severity results. Once again, very little difference between them. So this was the percentage of persons who reported experiencing symptoms moderately severe to extremely severely, and there was no statistical difference between the two groups. So essentially, from my study, what the end finding was that there were no significant differences between calcium supplement takers and non-calcium supplement takers in terms of their symptom severity, their symptom frequency, or their quality of life. So not taking supplements and just managing your condition with dietary calcium is certainly doable, and it was showing that people who do that are no worse off than what they were when they were taking supplements. That's actually all I have time for today. So thank you very much for listening. Please, if you have any questions, do pop them in the comments for me, and I hope to be able to address those for you. Thanks for your time.
Thank you, Tanya. This was really great. So it's Helen, yeah, there she is.
Thank you. Yeah, thank you so much, Tanya. That was a brilliant talk, and I actually learned quite a lot from that as well.
Thank you.
I'll start off with one of the first questions that I have from the questions list. Someone's asking about goat's milk, and I think they might be asking about how much calcium is contained within goat's milk.
Yeah, thank you. So can you see me? Has it come up yet?
Yes,
so
I can see
goat's, you. Yeah, goat's milk contains actually quite a similar amount of calcium to cow's milk, and it actually has a similar bioavailability as well. The issue with goat's milk is probably a similar one to cow's milk, and that's the phosphate content. So whilst it is a really great source of calcium and you can certainly use it throughout the day, it is one of those things to be aware of just how much dairy products or animal products you're having to obtain your calcium in terms of the phosphate content.
Oh, thank you for that. Yeah. Heidi, do you have any questions?
Yes. Tanya, we had a question on this iron metabolism and calcium, and there was a remark in the question and A that calcium might reduce iron absorption. Is that something you investigated? Do you have experience with this?
So it wasn't part of my study, but it is known that calcium and iron do compete for absorption. And so usually in cases where it's one of those things where if you're having more calcium than you are iron, then the calcium predominantly wins. So in cases in hypopara where perhaps we're focusing on the calcium in our diet, this could be slightly at the expense then of iron, so if each meal has got a high calcium content, then you may potentially absorb slightly less iron at that same meal if the calcium content is higher. So for those sorts of people, if you sort of realize that you are having potentially some issues, it's maybe good to separate some of those meals. So be looking at keeping spaces between, having a high calcium snack and then focusing perhaps on iron at one meal more than the calcium, and just allowing a bit of space so that those absorptions aren't competing. But yes, that can be definitely an issue.
Because I think it's interesting. Some patients need a lot of or love to take more calcium, for example. They to take, and also in the United States, very often they take like 3 grams of calcium. So that would mean that perhaps they are more iron deficient. Are you aware of any studies of this?
No, I actually haven't seen any studies on it, but it is, as I said, it's one of those things that
Yes.
certainly when we study that we're aware of it happening, but specific studies, no, I'm not familiar with that.
Yeah.
The high doses of calcium that, as you say, you do see in the States as well, are quite alarming, though, to be fair, and certainly not something that we endorse because, you know, as I said, we don't absorb that much. It's not physiologically possible to absorb that much calcium in one sitting. So there's certainly no need to do that, and to put, you know, your potentially you know, reducing your ability to absorb other nutrients at the same time at risk by having those large doses.
Okay, Helen, do you want to go out further with the other questions in the chat?
Yes, yep, I've got another one. So Tanya, someone's asking, in order for calcium tablets to work, such as carbonate, we need to have them with food. How much food is necessary, especially when one is not hungry?
You actually don't need a lot. So this is about the acidity of your stomach, basically. So calcium carbonate is absorbed better in the presence of an acidic environment, and you get stomach acid by eating food. So you really only need to have a small snack at the same time if you were having a supplement. It doesn't need to be a meal. It could just be, you know, just any food will increase, even thinking about food increases our stomach acid. So yeah, you certainly don't need to have a lot. It's not necessary to have a large meal. It could be just, you know, some fruit alongside or anything that you wish. Protein is particularly good to have alongside a calcium carbonate supplement.
There's a question from Germany which I can translate. This from Frauke Sieger. Are there numbers about vitamin B12 and hypoparathyroidism? Are you aware of vitamin B metabolism?
No, yes, it's not something I'm familiar with at all. And certainly I don't, as far as I'm aware, they don't compete, certainly for absorption in terms of calcium and vitamin B12.
Okay. Helen, do you want, there's
quite a few questions coming in for you, Tanya, so I'm just trying to make sure I get them all and I don't miss any. Did your study, Tanya, look at patients taking absolutely no medication, so i.e. no alpha calcidol?
No, not particularly. There were probably only a couple that weren't taking any alpha calcidol. And as far as I'm aware, those persons were still on quite large doses then of vitamin B, so of D3 or D2. But no, most persons in the study were taking activated vitamin D, and the average intake was actually quite low. It was only around 1 microgram or less. So it wasn't common to have people on quite large doses, which we actually found quite interesting.
Yeah.
So I do the next question. Here is one question what I think is really interesting. What do you think about calcium intake from eggshells? Somebody heard this from a patient. They use a mortar and add some yogurt, for example, and then they say, "Great talk, congratulations," just for you.
Thank you. So the calcium in eggshells is just calcium carbonate. It is not, you know, it's not a special type of calcium. Calcium is actually quite a basic mineral. And it is bound to other things, so calcium phosphate, calcium citrate, and the difference between all of those is, of course, the amount of elemental calcium that's present. So the eggshells is just calcium carbonate, as you would find in a calcium carbonate supplement. And yes, you can grind it up if you wish and consume it. I don't imagine it's very palatable, but you know, I've known of people to put it in smoothies and all sorts of things, and that's actually fine. And it is absorbed at around the same rate as, say, milk or any other animal product of calcium carbonate.
Okay, that's interesting.
As I said, I don't know that it's the most palatable way to get your calcium. It's certainly natural, but yeah.
Interesting one. I might not be adding that to my smoothies just yet.
No.
There's another question come through. Oh, it's just jumped. Hang on, just bear with me. In your opinion, is it still better to take calcium only through food?
In terms of protecting our kidneys and in terms of reducing calcium phosphate product, yes, most definitely. As I said, I think, you know, going back a long time before activated vitamin D existed, so going back in the 70s, the only way to treat hyperpara was to give people normal vitamin D and a massive doses of calcium. Because I think the other thing to take into consideration is when we absorb calcium, we actually have two pathways. So one pathway is vitamin D activated. So that's where we, in the presence of parathyroid hormone, vitamin D gets activated. That vitamin D then helps us absorb calcium. That pathway only works for very small intakes of calcium, so sort of 400 micrograms and under. Once we start having bigger serves of calcium, that pathway then becomes more like diffusion. So it goes from, an area of high concentration to low. And as of all diffusion processes, there is there's a saturation point. So when you start having large doses, you've saturated your ability to use the vitamin D pathway. You then start saturating your ability to do the diffusion pathway, and then the rest you just excrete. It doesn't actually get absorbed. You're going to poo it out, essentially. It's going out with your feces. So having these really large doses of supplements doesn't mean you're going to absorb more, because physiologically you do have this limit. So yeah, and then of course what you do absorb as it does enter the bloodstream, and it does end up in our kidneys. And we do need to be aware of the calcium phosphate product that exists from over-consuming. So if you're having your calcium from food, it's much harder to over-consume.
Okay, thank you, Tanya. Heidi?
Yes, I think there's an interesting question. Now, you did a lot of studies, Tanya, on this. What is your personal attitude towards calcium? Would you prefer to take it with the food, or would you say, because you showed it's more or less the influence on the different aspects is not different. Would you prefer to take medication, or would you try to do it with your food? So what is your suggestion?
I think when it comes down to it, at the end of the day, for most people, it is a personal choice, and it is what's convenient for you. And perhaps even that will vary daily. What's important is that we do learn to listen to our body, and we learn to manage our symptoms. And if in an emergency situation, taking a calcium supplement is necessary, then certainly that's what you can do and should do. Personally, I think from a day-to-day basis, I try to manage totally with diet. I find that way I can tweak it better. I can have smaller amounts. I can add more in quite easily. Taking a supplement means, you're sort of ad hoc breaking it up, and you're never quite sure how much you're getting, or if you're suddenly having a large amount, or you haven't had quite enough, and you can quite easily add in too much. With food, it's a little bit different. It's a teaspoon of yogurt, maybe a couple of almonds, and see how you feel after a little while. And if that doesn't work, you can add in a little bit more or a little bit more. So definitely diet is the way to go. And as I said, it does help prevent us from over consuming calcium, and it does help reduce then the amount of phosphate that we're having. And just, trying to find that fine balance. So it isn't easy. And as I said, the study did show, unfortunately, I was really hoping that the people just taking dietary calcium would be managing the condition better. But at the end of the day, taking calcium is not a replacement for the hormones. So the symptoms response is quite similar. So it is then more about protecting your kidneys and reducing those calcifications.
Yeah, it's a really good point, that, Tanya, isn't it? I think in my mind, I would have expected or hoped the nutrition would have done better than taking supplements. There are quite a few questions about what kind of calcium do you prefer? So citrate, lactate, etc. And that's going to come up a couple of times in the questions as well.
It's calcium carbonate is kind of the one that is around the most. It's the cheapest to produce. It's easily absorbed, and it does contain the most amount of elemental calcium. So that's what's generally given. Some people find, and of course with carbonate, you do need to have food with it to digest it and absorb it. Citrate doesn't need food because it's already a higher acidic product. So it is easily absorbed, but it does have less elemental calcium in it. So if you are relying on products with calcium citrate, be aware that you may need more. than what you would have if you were taking a calcium carbonate supplement. Again, it really is about personal choice and what you can tolerate. A lot of people do have gastro problems with calcium carbonate. It does cause constipation and stomach ache, and sometimes people find they don't get that with calcium citrate or other types of calcium. But essentially, calcium is calcium. You know, what the difference is what it's bound to, and that becomes then an issue of what you're tolerating in terms of symptoms. And if you're finding calcium citrate is managing things well for you, then certainly, you know, that's fine to do. But I really would recommend, where possible, do cut back on your supplement intake and do try and manage more with diet, just in terms of kidney health.
Yeah, that's interesting as well. Thanks, Tanya.
Pleasure.
We've kind of finished this
Yes.
session. Thank you so much for your questions. We do have a Q&A, an open Q&A at the end. So any of those questions we will have a look through in the next talk. I'll hand over to Heidi to introduce the next guest. Thank you.
Yes, yes. Thank you, Helen. And Tanya, this was a really great talk, and that you do research on it is really, really important. So thank you for this. So I'm happy to present you our next speaker. This is Dr. Andrea Palermo, and you heard already something from him. And this is exactly what he's working on. He's an endocrinologist, diabetologist, and assistant professor of endocrinology at the University Campus Biomediche in Rome, Italy. Since his PhD, he focuses a research interest on calcium and bone metabolism, especially new diagnostics, as we heard, perhaps the calcium measurement, and therapeutic aspects of clinical and subclinical forms of parathyroid gland diseases. He has published more than 120 papers on parathyroid gland disease, diabetes, and thyroid disorders. He's a senior academic editor of Endocrine Connections Journal and a recent awardee of the European Journal of Endocrinology Rising Star Award. And he's a really good friend because he does a lot of research on hypoparathyroidism, and I'm really happy now that he's here. So please, Andrea, go ahead.
Good morning, everyone. It's a great pleasure to be here with all of you. And now it's time to talk about the new treatments for the management of chronic hypoparathyroidism. And as we have a short time, let's get started. We as a doctor and you as a patient are fully aware that the calcium level should be in the normal range or slightly below the lower limit of the normal range. And probably this is one of the main goals that we should get in the management of this clinical condition. But unfortunately, not all the doctors are aware that we have a lot of general goals that should be achieved. For instance, it's important to normalize the 24 urinary calcium excretion in order to preserve the kidney function. It's also important to maintain the phosphate, the magnesium in the normal range, and also to achieve an adequate vitamin D status. But unfortunately, most of doctors usually forget that our main goal should be the overall well-being and the good quality of life for our patients, because we usually focus our attention on the calcium and phosphate balance, on the normalization of the 24 urinary calcium excretion, and we forget that our patients are characterized by loss of memory, brain fog, loss of energy. We usually forget that their life changed, and we should focus our attention on this aspect as the main clinical guidelines suggest. But the real question is, how can we get all these aims? How can we help our patients to have their life back? Because sometimes we try changing different treatment, changing the calcium and the active vitamin D supplementation without obtaining any clinically relevant results. And if I were in patient's shoes, I would think, but come on, this is a good doctor. This is the right person that can help me, because he changed my treatment several times, but I still feel so bad. what we have to help our patient. Of course, the first line treatment is based on the conventional therapy, and the conventional therapy consists of the calcium supplementation, the active vitamin D supplementation, mainly the calcitriol and alpha calcidiol. Active vitamin D means a powerful vitamin D that can help the calcium and the phosphorus balance. And we have also other supplementation such as the magnesium supplementation, and sometimes we use some diuretics in order to for calcium. Because talking about the conventional treatment, only 30 old clinical aims that we mentioned before. And the most frequently unmet targets are the 24 urinary calcium and the calcium level, and I would add even the good quality of life. So in other words, about 70% of our patients are not able to achieve a good control, even if they are followed by a very skilled doctors in a good hospital. This is the main reason why the clinical guidelines suggest us to consider the use of the PTH analogs when the conventional treatment is deemed unsatisfactory. When we talk about the PTH analogs, we refer for sure to the PTH 184, that is the full molecule. It's a therapy that consists of once daily subcutaneous injection on thigh, and this treatment has been approved in 2015 in USA and 2017 in Europe. But unfortunately, the company decided to discontinue the drug production, so after December 2024, this treatment will not be available anymore. We have another option that is the PTH 134 that is called teriparatide and consists of the first part of the hormone of the PTH that is able to exert its biological effect. The treatment is based on once or twice daily subcutaneous injection, but I want to remind you and I want to underline that I'm talking about an off-label use of the teriparatide that we usually prescribe for our patient affected by severe osteoporosis. But I'm really glad and happy to say that the future became present, and the present at the moment has only one name, that is the Palopeg teriparatide or Yorvipath. I'm talking about the real replacement therapy for the management of chronic hypoparathyroidism that has been approved in November 2023 in Europe, and recently, about 1 month ago, in US. I can imagine that it's hard to understand a slide like this, but to me, it's really important to let you know and to let you understand the mechanism that can explain why this drug is so innovative and can provide a stable PTH levels in the physiological range for 24 hours a day. So, as you can see here, the orange stuff, we have a molecule of PTH that is the teriparatide. As I mentioned before, I'm referring to the first part of the PTH that binds a carrier via a linker. And it's important to talk about the carrier because it binds and shields and protects the PTH from the enzymatic degradation from the body. But following a single subcutaneous injection and upon exposure to a physiological temperature and pH of the body, there is a kind of autodestruction of the linker. So the PTH doesn't bind the carrier anymore and is free to exert its biological effect on some target organs such as kidney. And finally, this drug looks up a lot to the impact. And here you can see the tool with and also the is on the here you can see the tool with its needle, and of course the treatment is based on the subcutaneous injection of the drug on the abdomen at least 5 centimeters away from the navel or on the thighs. But the following question is, can this drug really help all of you to achieve all the clinical goals that we mentioned before? It's really effective in improving your quality of life and your daily life. So in order to address to all these questions, I want to introduce you Maria. Maria is one of my patients, and a few months ago, she told me, "Doctor, please, I need help. That thyroidectomy changed my life, and now I want my life back." So these are the main reasons why we proposed Maria to start a new therapy. And these are the main results coming from the new treatment based on the once daily injection of paloperidol. Look at the blue line. This represents the calcium level over the time, and as you can see here, after a few weeks, Maria achieved a very good calcium control. And looking at the orange line, we obtain a very stable phosphate level over the time. Despite of a significant reduction of the calcium supplementation over the time, in this case from 4 grams to 500 milligrams per day, despite of the full discontinuation of the active vitamin D supplementation from 3 micrograms to 0 microgram of calcitriol. And most importantly, please listen to Maria's thought. Doctor, remember when I talked about the brain fog and the loss of memory? Now, definitely I feel much better than before, and I'm pretty sure that the drug is working properly. So, finally, I can confirm that this drug is able to improve the quality of life of you. In other words, using this drug means that you obtain a 98% probability to discontinue active vitamin D and a 93% probability to be independent from the therapeutic doses of calcium. And this is a huge achievement when you compare the efficacy of the paloperidone to the conventional therapy and look at this number in the table. So when you use the conventional treatment, you have only 24% probability to be independent from the active vitamin D in comparison to the 98% probability of the paloperidone. And importantly, as I told you before, this treatment achieves an improvement in quality of life related to both physical and mental health. And we have more because for the first time, a drug used to treat patients with chronic hypopara clearly showed a significant decline of the 24 urinary calcium excretion from very high level, look at the first green bar, to a normal levels. And we have also a confirmation that the treatment is able to improve the kidney function over the time, dark dots, compared to a significant reduction of the kidney function over the time in patients treated with conventional therapy, the white dots. And we have other good news, and one of these is represented by eneboparathyde, that is an investigational peptide, so a kind of protein, able to strictly bind the PTH receptor, so it can exert a very powerful and long biological effect in the place of the PTH native hormones. And here you can see as it looks like. As you can clearly see in these slides, eneboparathyde rapidly eliminates the need for active vitamin D on the left and the need of calcium supplementation on the right, moving from very high dosage to the fully discontinuation of active vitamin D and calcium supplementation. Maintaining calcium level in the normal range in a very stable manner, as you can see, look at maintaining the calcium level in the normal range in a very stable manner, as you can clearly see looking at the green light. As this is my last slide, I want to share with you some very interesting future perspective due to the development of some new drugs, such as an injectable long-acting PTH analog, in other words, a weekly formulation of the drug, or an oral PTH molecule, so a kind of pill, and also some antagonist of calcium sensing receptor, so a new way to treat a particular form of hypoparathyroidism called ADH1. But generally speaking, I want to underline that other 13 drugs will be developed in the next future for the management of hypoparathyroidism. So we can state that finally the future looks bright. Thanks a lot for your kind attention.
Thank you, Andrea. Thank you. That was a very interesting talk, and there are a huge number of questions. So the future looks more bright than before. So there's a question, we should start right away. So just to remind you, we have the special Q&A for Dr. Palermo until 12:35. And then you can ask all your questions you want to ask to all our speakers. So we just start with now the new drugs. So what about children? Is there an outlook for PTH therapy for children, Andrea?
In the next future, we hope.
Okay, nothing especially yet. Okay, so there's another question on to compare this like the pump. So what is the main difference between for Theo and Yorvipart, because both are 1 to 34. Perhaps you can just repeat this for the...
Okay, now I need just 1 minute to address to this question because it's a bit complicated, because you know exactly that using pump, we have the opportunity to normalize even the 24 urinary calcium excretion. So ideally speaking, in the way we can even prevent some kidney complication. But you know exactly that it's quite hard to manage this kind of treatment that is firstly an off-label treatment. The insulin pump has a lot of trouble with the temperature, the storage of the drug, and you have to be very skilled in order to use the kind of technology. Instead, with Yorvipath, of course, we are using again teriparatide, right? But the difference consists of the technology around the teriparatide, that is the transcon. That can provide a very long half-life for the drug that can last over than 24 hours with only one injection, subcutaneous injection. And with only one injection, we have data that confirms how it performs well in terms of reducing the 24 urinary calcium excretion and directly to maintain stable and to reduce the potential decline of the eGFR over the time. I don't know if I addressed well to the question.
But can you just comment again on the half-life of both molecules, perhaps?
Yeah, of course. You need the pump because and the continuous releasing of the drug because of the short half-life of the teriparatide. Instead, when you use the Palopeg teriparatide, the technology around the Palopeg teriparatide can allow to or provide to the drug a very long half-life, and the drug can last over than 24 hours.
Okay, thank you. So Helen, you just drop in if you have a question. I just continue with another question, which I can see here. There's a question, do you have any comparisons between the health of patients who were on teriparatide and those who switched to Yorvipath? So we would like to know if it will be more effective than teriparatide, as you seem to be comparing only with conventional treatment.
I think that probably you will have this kind of data. So in the next future, we will have this kind of data, managing the switching from teriparatide and Natpara to the Palopeg teriparatide. So not at the moment. In the next future, yes, we will have data, but I can state that, of course, Palopeg teriparatide is definitely a real replacement therapy compared to teriparatide that is just a PTH analog treatment.
There's another question. When do we wait for enoboparatide? Do you know already when it will be available in Germany or in Europe?
I have no data about timing, but as you know, we are running the protocol, of course, and our patient are really in a very good control at the moment, but I have no idea about the time. So I'm sorry, I cannot address to this question.
Mm-hmm. There's a special question on the amount of treatment with Yorvipath. So there are 3 pens, and so somebody said, "Oh, I don't know with which one to start." So do you want to comment on that?
Yeah, of course. Company and our clinical experience from Yorvipath suggest us to start with intermediate dosage, and then you can adjust and titrate the dosage according to the calcium level and according to the amount of calcium and vitamin D that you are taking.
Exactly. So you take the medium pen, 18 micrograms, and check like after once a week. So this is the way how to do it right now.
Yeah.
Okay. What is the long-term side effects of PTH replacement?
Long-term side effect, but I would say that at the moment we did not record any a particular important side effect. We have now data regarding the bone safety, and we can say that our data are confirming that this kind of drug is safe for our bone and even for other biological system. So,
Helen, do you want to continue with it?
There's a question from Liz, actually. So in the Parathyroid UK group, there is some concern about the potential difficulty of transitioning from conventional therapy to PTH. Are you able to comment on that, please?
Ida, I don't know if you want to address to this question, as you have a huge experience regarding this topic, because you know that in Italy
Yes.
it's been approved, but at the moment we don't have the reimbursement for the drug.
Yeah, so we are we're on the way to publish the data from the first month right now. So we have experience for 1 year now with the drug. So with the change is how we did it is that we stopped PTH 1 to 84 that day with a new application. We started all with 18 micrograms. And surprisingly, there's no correlation. So if you had before 100 micrograms or 50 micrograms, so there's no real correlation to the dose. So always started on 18 micrograms, and just that day, no application of 1 to 84. And then adapt. We control after 4 days and then every 7 days. So just to know after 4 days if it's too high or too low. And that went very, very well. What I always say, every patient had my phone number and nobody called. So it was like really it went really well. So don't be scared. It will be okay.
Yeah. There is another question here that says, if you can't tolerate the tetraparatide treatment, is the new treatment possible?
Oh, sorry, Ellen. I lost you for a few seconds. Could you please repeat the question?
Yes, no problem. It's if you can't tolerate the teriparatide treatment, is the new treatment possible?
I would say yes, because the grade of tolerability is very high. So yes, I would suggest it.
Yeah. Is it expensive?
Yes, very, very expensive. This is why we are waiting for the reimbursement of the drug. I think it's impossible to suggest in this moment in Italy this drug for our patients a lot.
Can you put any cost on it, Andrea? You say expensive. Can we put an approximate?
Yeah, about I don't want to say nothing that is real, but I think 30,000 euros, 30. So, but I don't know. I don't want to.
So.
Yeah.
So it will be 10,000 a month in Germany. 10,000 euros a month.
So a lot.
Yeah, it's similar to some of the other hormone replacement, isn't it? Like growth hormone replacement is really expensive as well. Are there any studies, can test results distinguish between PTH of the remaining parathyroid gland from the PTH replacement?
So if you measure PTH in the blood?
Yeah. But I don't think there is any correlation, but anyway.
But you measure it. So if you are treated, I mean, you will measure it in the blood. So and there's so the best is if you want to measure the PTH, what is there, to measure it before. So if you have the treatment, you will measure higher PTH levels.
Yeah. Okay. Perfect. With your experience, how have people been able to improve their quality of life? So what was measured within that quality of life on the path?
You know that now finally we have questionnaire. We have validated questionnaire in order to measure the impairment or the improvement of the quality of life. And for sure, I can say that our patients treated with teriparatide experienced a very improvement, a very good improvement of the quality of life. I mean, it's mental and physical health.
Do you find that they can return to work if they've not been working, or are they able to exercise? Because that's another thing that a lot
Absolutely,
of
yes. Yes,
yeah, so
absolutely.
they can just go back to, would they report that that's, I feel exactly how I was before?
Not exactly, but pretty close. Pretty close.
Okay. Yeah, it's better than nothing.
Yeah, no. It's a good achievement, a really good achievement.
Exactly. Yeah, being able to do any exercise.
So
There's one more question before we move into the open. What symptoms do persist after UV-Path?
So as you said before, pretty close to the old life, not the same. So sometimes my patients refer a kind of slight weakness, and something about the loss of memory that is not fully recovered. But this is just my personal experience. Okay.
Yeah. Thank you.
Okay, so thank you very much, Andrea, also for this great discussion in the end. So now we open the forum. Helen and I open the forum for please all presenters, please show your face to all of us. And so we are now open for all we can ask all the questions you wanted to ask to all our speakers if you want. So what I think is really interesting is about the quality of life. And so just to comment the question to Andrea, what stays. And my experience is if you have like hypoparathyroidism for 20 years, then there's a lot of symptoms which won't go away. That's what the feeling. There's no study right now, but if you just have it very shortly, perhaps it will be a full recovery. So at least this is something what seems to be like that from the phase 3 trial. So, but we will see. So there's a lot of research to be done. So now we have some other questions about the calcium sensor antagonists. What is the state of research at the moment? Who wants to answer on this calcium sensor receptor antagonists or agonists? Tanya, you want to comment on that, or Andrea?
Tanya, if you want to, you can go ahead, or
Yeah,
I can say something if you want. We are running, you know that there is a protocol that is running at the moment for patients with a particular form of hypoparathyroidism. And there is a drug that is a new drug that is providing a very, very good response. And so the future again is quite bright. I'm talking about the encaleret.
Okay, so here's another question which I don't actually also know. Can an expectorant be changed if you know you're intolerant to one? For e.g., metacresol, what is in Yorvipath? So what do you think about this? So this is like if there's something in the medication in Yorvipath which you're allergic to. So what is the way to treat it? Do you think like then they have to take higher doses, or perhaps they have to take the pump? So otherwise, what is your Andrea?
So, sorry, Ellen, because I'm experiencing some trouble with my connection.
Okay.
But anyway, yeah, you suggested the alternatives. So, you mean you have to go back to the other treatment, of course, or to the previous treatment. It depends on the patients.
Okay, so perhaps
Oh, sorry, Heidi. I was saying there is another question coming in.
Yes, great.
If you want to finish off on that one, sorry.
No. I just wanted to think if one of the speakers have questions or comments, please go ahead and just unmute yourself and comment on it, so that we have a lively discussion. You can just drop in and share your experiences.
There was a question regarding the physical activity, and probably we didn't reply yet. And if you want, I can share just a paper published a couple of years ago in the chat, where some Italian experts in the field suggest a kind of protocol regarding the physical activity for our patients with chronic hypopara.
Please.
Really useful. Yes, please.
Okay.
Also, in the
Okay.
meanwhile, I talked to a friend who is a professional chef and uses the Thermomix, which is quite widely available now. And she said, you know, with the eggshells, she does that for her garden. And she would advise if somebody wants to eat them, you need to cook them before, because salmonella is on the eggs outside. So you need to cook the eggs before. And she said one eggshell usually is 6 grams, and she can make a very fine powder, but she hasn't tried yet to put it in food.
That's really good. Thank you for that. It's important to note to cook it first.
So here is a question: how many times per year should you monitor calcium in the 24-hour urine? So, Tanya, you want perhaps to answer on that? Tanya Sikia. Yeah, no, we have several Tanyas. Sorry for this.
Yes, yeah. I think in the beginning, I would like to do it once a year. And then if you have normal calcium excretion in the urine, or calcium levels in the urine, and you don't change your diet that much, I probably would do it every second year, something like that. But hopefully with the PGH treatment, if we are allowed to treat a lot of patients with it, this might not be the same issue any longer.
Yeah, very good. Thank you for that, Tanya. There's
but to note, I know that a lot of places this is not done. So as patients, you should remember your doctors that it's important you have your 24-hour urine measured from time to time.
Yes. Another question that's come through: are skin problems common with hypopara patients? So I'm thinking this could be to any of us, really. Anyone want to answer that one?
I saw that in the questions and I thought, I don't really know what to answer.
No.
Because, sorry, I would mostly think it's the ones that have autoimmune disorders. I don't know what. Someone talks about a bit of dry skin, but that's everything I've heard. I haven't heard anything other kind of skin diseases.
I've
Have
only
you?
heard about dry skin. I've heard about it, but I don't know if it's. Yeah.
Also, itchy skin can be an issue that some people experience, but that's sometimes related to phosphate levels. But I imagine they'd need to be very high before that became an issue.
So I have another question here. So somebody talks about that the daughter was diagnosed with global developmental delay with hypoparathyroidism, and she asked, he asked that that if it is combined with a hypoparathyroidism, but if it's a daughter and a child, perhaps we asked Stella, so if she has experience with this, but because for a little bit it sounds like if it's a genetic disease, then there could be also combinations with it. So if because Stella, I thought you are in contact with a lot of families would also have perhaps children with hypoparathyroidism. Do you have also experience with developmental delay in these children?
Yes, so if it's congenital, then many times this comes with a syndrome, so with a genetic disorder. So it actually depends. For example, many children that have the 22q11 deletion, so the George syndrome, they do experience developmental delays and impairment of cognitive function as well. But it comes with the syndrome. We don't really know how much we can blame it on hypoparathyroidism and how much is actually the syndrome itself. So it can affect development, of course. And actually, I wanted to mention earlier that as a parent, when I attend events like this, they are extremely useful and so informative. And thank you so much for organizing But sometimes they're a bit frustrating, and I'm going to explain why. Because usually when we are talking about the quality of life, it's not really taken seriously with children, the quality of life. And I think a reason for that is that a child that was born with it can't really ask for their life back as it was before, because they have no comparison. This is what they know. So they are born with it, and they just assume everyone is dealing with the same symptoms, and which is not the case. And for example, my son is a teenager now. So if I'm mentioning to the doctor that my son has sometimes issues concentrating at school, or sometimes has memory problems, or he feels very tired, these symptoms are overlooked, and they just say, oh, this is something that all teenagers experience. Or so quality of life for children is not actually taken seriously. I've noticed that for many years. When in adults, when you have acquired hypopara, you can compare your life before you had it and your life after you acquired it. And you know that that's not normal what you're experiencing, and you can advocate for yourself to gain that normality again. Whereas in children, they can't do that. This is all they know. It's a bit tricky, and being a parent of a child with hypopara is tricky. So yes, it affects in many ways: development, cognitive function, performance in school, and it's not acknowledged many times, especially in schools, because they just look like a normal child. They don't.
The results before and after.
Thank you, Stella, very much for this input. So we have
the same question. Yeah, sorry, but in the same question, there was something with teeth development. And that is true. If you have it, if you're born with hypopara, there's often late development of teeth, and you can have manual defects. So because you have low calcium, then you won't have calcium in your teeth as well. It's just a comment to that question.
So there is a question on PTH treatment in osteoporosis and hypoparathyroidism. If you can treat as the double problem, if there are any studies. So perhaps also Tanya Sikia or Andrea, who wants to comment.
There's no good studies on that, and it's a very difficult thing. It's normally a problem in the patients who have post-surgical hypopara, which had the surgery late in life. So the patients have postmenopausal osteoporosis, and then they have hypopara, and these patients can be a bit difficult to treat because with the hypoparathyroidism, you actually reduce the bone remodeling very much with when you only have conventional treatment. And then it doesn't really make that much sense to treat these patients with, for instance, bisphosphonate to also reduce the bone remodeling. But if the patients, so you just need to bear that in mind when you treat the patients. And then that said, I know that some of the patients are still treated for osteoporosis with hypoparathyroidism. So it is a bit of a difficult thing.
Yeah.
So Helen, do you want to continue perhaps?
Yes. Someone's asked, does UVPath suppress pre-existing parathyroid hormone?
Yes. I would definitely guess so. So if you have high levels of PTH, then it will probably spread. Oh, sorry. If you treat with PTH injections, then it goes that high that it will suppress. I'm a bit unsure with the new treatment because the PTH levels doesn't go that high. But then again, it's probably just a very tiny bit that the patient produced. So I don't think it makes any difference whether it's suppressed or not.
I agree.
But you would measure it in the blood, no? If you do
it's
a blood sample
shortly
after, your PTH is super high, but it's from the drug.
Yeah.
Thank
Okay.
you.
So here's a question on if parathyroid transplantation has ever been focused on. So I want to comment on that.
No.
So I can.
Yeah. Sorry.
So there's just one study and one patient to comment on that, and the problem that worked like that was a relative who gave parathyroids, and it's also a question of suppression of the immune function, what you have then in addition, because that's then from another person. So this is as far as I know, this is the only study. So perhaps does anybody know of other studies than the one from Germany, which is published? So it's not really focused on right now.
Yeah, so
with the treatment we have now, I don't think it would be recommended. Okay. There's much better treatment than transplantation.
So I mean, it's really good treatment if you have like a half-life of 60 hours with the PTH analog, right? We have now.
I mean, it could be relevant for the special group for patients who have secondary hypopara after renal hyperpara for a chronic kidney disease where they need kidney transplantation. They may just have parathyroid transplantation along with it and have no additional immunosuppression.
That's true.
That would not be acceptable in a just hypopara patient, I think.
Okay.
I know of a situation regarding the transplantation of parathyroid gland because I'm involved with children who are missing a thymus as well, and most of them are missing a parathyroid or they have a very little PTH level. There was a situation when a child who had a thymus transplantation had also, and there are several actually situations in the United States, they have had several patients who also received the parathyroid transplantation in the same time. It's a bit tricky because with the thymus transplantation, we actually want to restore the immune systems, and we don't want to use any immunosuppressants. And I do know of a situation in the UK of a child that has received, in a way, accidentally has received also parathyroid tissue along with the thymus, and actually restored both immune system and parathyroid function, which was amazing. But these are really rare cases.
And are they published?
I will ask. I'm not really sure if that case was published or not. I will ask.
Should be.
Should be. It was an similar case.
There is one question on encaleret on if it's only used for calcium sensor receptor changes or if it will be used also in regular hypoparathyroidism. Who want to comment on that?
No, only for ADH1.
Actually, there are studies at the NIH in New York, as I know, that they just studied it and they presented first data in a meeting, and it was surprising that with this encaleret that PTH was increased, so it seemed to stimulate it. So but it's a study, just a single center study I think in New York. So we'll wait for the results, and we don't know if we can use it in hypoparathyroidism in post-surgical. So here somebody says there's research in Newcastle University on parathyroid stem cells for hypopara patients. Thank you for this news. This is really great. And here is they have done a parathyroid transplant in Canada recently. So there's information. I did not see that's published. So Stella, you have a comment.
No, it's not related to the transplantation of parathyroid tissue. I had a question from some patients that they're asking on my WhatsApp. I had a question regarding the dietary supplementation of calcium, because some patients receive from their dietitian, they receive the advice to avoid foods that are high in phosphates, but usually foods that are high, food products that are high in calcium are usually naturally high in phosphorus as well. So for example, dairy products, milk, yogurts, nuts, and soya. So what can be done about this in a diet that needs to be low in phosphates due to the body's inability to eliminate it?
Do you want me to have a go at that one?
Yes.
Yeah, that's actually very difficult because calcium is usually bound to phosphate in many foods. The phosphate bioavailability also changes depending on the source. So if you're looking at phosphate from animal and dairy products, then you're looking at a bioavailability of around 60 to 70%. So that's quite high. If you then look at phosphate from plant sources, it drops down to about 50%. So that's coming then because of the phosphate binds with phytates in those cases. But the biggest issue in phosphates actually tends to come from inorganic phosphates, which are the ones that are added. So they are in fast foods and in processed meats, and you'll find them in bread and all sorts of things. They're put in there endlessly. If you look at any food labeling, you'll see, PHOS kind of there, or a whole bunch of E's with some numbers, and quite often they are phosphate additives. The problem with these is they have a bioavailability of 100%. So when you're looking at reducing phosphate, it is exceptionally difficult because it is very common. But essentially, it's firstly getting rid of all those added inorganic phosphates because you're going to absorb most of them. And then it would be a case of reducing dairy and meat products. So potentially having more fish over meat and limiting serves. Dairy is usually not asked to be totally eliminated, but it can be reduced to kind of a serving a day. And then you're looking at predominantly then at vegetable sources because they're not as bioavailable. But yeah, it definitely, a low phosphate diet is exceptionally difficult to follow and isn't usually recommended. It may be the advice given by dietitians in sort of, high stages of chronic kidney disease. But yeah, it is a tough one to follow. But definitely look at getting rid of the inorganic phosphates, absolutely number one, because of their bioavailability.
So we come close to the end, but I would like to that Tanja Richter and Nathalie Grosset, if they want to add something. Nathalie, if you want to add at the end, because perhaps a comment or something, because you didn't took part of the discussion right now. Perhaps you want just to add something before we close. No, but we can't hear you. So if you want to say something, please unmute.
Well, I'll be doing the closing, but what I could add,
yes,
my husband has just left. As far as the caregivers, for the caregivers, obviously, it's not very easy for them because as hypopara, we could be a little bit all over the place. But it's what they need to just manage to figure out our symptoms, I guess, like a calcium monitor as well, and know when to be there for us and when not to be there. Sorry, my husband just left. He would have been the one saying it, but to just be able to not overreact, because it's due to our condition. It's not due to who we are. But then I'll just go on with my closing.
Yes, thank you. So, and Tanja, do you want to add before we give over to Nathalie and Andrea? But perhaps you want to add something for this discussion from the...
No, just thank you very, very much to everyone who participated today and also who organized.
Okay, then I thank you to all the speakers, and Helen, I think thank you all also for sharing the session together, and then I hand over to Andrea and Nathalie.
Nathalie, please.
Yes, I go. Yeah, so sorry, I have written it out because my memory is not too good. So anyhow, on behalf of all of the European hypoparathyroidism organizations, thank you very much to everyone who joined today's session. And we sincerely hope that it has provided valuable insights, helping you and your family members to better understand what hypoparathyroidism is about. Obviously, as every year, a special thank you goes out to Tanya Richter from Germany, Magda from ESE, as well as Andrea and Heider. And let's not forget Liz from the UK, Helen and Pernian from Norway, and all of the dedicated patients and clinicians who have helped prepare and deliver today's session. So as we closed this year's webinar, last year I talked about I Have a Dream. Well, this year I'm going to talk about the Paralympics. So as I leave, I want to leave you with a thought that actually stayed with me while I was watching the Paralympics this year. As I was witnessing the courage and the resilience of the athletes with visible disabilities, I found this very inspiring, for the least. But it actually left me reflecting on the burden we carry with hypoparathyroidism, because it's an invisible condition. And I was like, imagine if they were glasses that could reveal the internal struggles we face, the malfunctioning of our missing parts of our bodies that no one can see. So just imagine if people could see how our nervous system struggles to function, how essential calcium is for our nerve connections to work. If they could actually visualize and see the brain fog and how exhausting it is for us to just think through it, or how difficult it becomes for us to concentrate. And imagine if they could witness how our memory pathways and brain connections misfire, and how the simplest tasks for us can be an enormous amount of mental effort, and how often we forget things, not because we aren't trying, but because our mind simply can't hold on to the information as it should. So if people could also visualize our internal trembling, the pounding of our hearts, and the calcification through our bodies that cause us pain, if they could grasp the invisible exhaustion and see the physical effort it takes us to just keep going, would they still be judging us as lazy or dismiss our symptoms as exaggerations? And I believe they wouldn't. I would believe they would be in awe of the strength it takes us to live with an invisible condition like hypoparathyroidism. They would not see weakness, but resilience, and an unspoken strength that powers us through each day. So we may face, each one of us, unique challenges, but our ability to persevere, to keep going, is proof of our incredible inner strength. So let's continue advocating for ourselves and for each other, knowing that even though our struggles may be invisible, they're no less real. And so is our determination that this condition is known. Thank you once again for being part of today's webinar, and let's continue moving forward together. Thank you.
Thank you very much, Natalie. Thank you for these kind words. I think that very thoughtful as usual. On our side, the European Society of Endocrinology, ourselves, the commitment in terms of the advocation for the patients like you and all the others is maximal. Our efforts are all towards, in the end, the well-being of our patients. So you can sometimes think that we are a little bit distracted, that we think about politics or academy or hospital problems, but as you know, and as all the other people know that are connected today, our thoughts and our efforts are all focused on improving the well-being of our patients. And I think that this mission is what makes our work not like a job, but like something else, which is made of comprehension, compassion, and action, because in the end, action on our side is what is needed to improve the conditions that we treat. So basically, I think that this joint venture with the patient association, with the patients themselves, is something that in the end should be found in every activity, and an alliance that is important also for practicing. So really listen to the patient and not under-evaluate what is the patient feeling. And this is a part of our work, and this kind of work is a fantastic experience for everybody of us as clinicians. So I think that we already have more than 100 people connected. So this shows that the success of the meeting also this year was huge. And congratulations to all the speakers, to all the clinicians speakers, to all the patient speakers. Very, very nice fil rouge that really was evident during the whole duration of the meeting. I think that I can close assuring everybody that the European Society of Endocrinology will work towards a 4th edition of this forum, and the forum is just the visible part of the activity, but we will continue to work in this field, and the commitment is maximal for improving the condition of hypoparathyroid patients. Thank you very much to all for your patience, your contribution, and your relentless effort towards improved collaboration between clinician and patient. And see you all next year, hopefully. Ciao, everybody. Ciao.